Every patient that comes in is more scared of the anesthesia than they are of the actual surgery. And anesthesia, for the most part, is very safe. It's actually safer to go under anesthesia than it is to actually come to the hospital statistically.
This is the Man Up Podcast, a doctor's guide to men's health.
If you've been enjoying listening to our podcast, please hit the subscribe button on YouTube, Spotify, and Apple Podcasts.
My name is Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. This week's episode is titled Out Cold, Talking Anesthesia with Dr. Zain Hasan. Today we're joined by Dr. Zain Hasan. He's an anesthesiologist and medical influencer who, like us, wants to make medicine simple for the average person. He has great content online, and we're really honored for him to join us here today on the podcast. Zain, thanks for joining us.
Hey, anytime. Since I saw you guys over at Health 2025, I was excited. Could not wait to be on here with y'all and talk some anesthesia, but also talk a little bit of urology stuff that I never ask questions about, but I should because I'm getting older. So excited.
Yeah. No, honestly, thanks so much. And it was great meeting you in person. Kevin and I both were so inspired by that conference, and we really liked connecting with you. And we really wanted to make sure you came on because you have a really good way of communicating with people online and taking complicated ideas and, sharing your thoughts on them as well. So thanks for coming on, and we're pumped to have you.
Absolutely. Let's do it.
Let's do it.
All right. Question number one. So what do you think is the most common misconception about anesthesia?
So yeah, this is a great question. I covered it. I try to cover it in my on my social media a decent amount, but every patient that comes in is more scared of the anesthesia. Not every patient, but I would say probably, 98% of people are more scared of the anesthesia than they are of the actual surgery. And if they understood, anesthesia for the most part is very safe. I mean, it is like 99% safe. 1% of 1% of the time I'm saying figuratively, but it's less than that. But it's actually safer to go under anesthesia than it is to actually come to the hospital. Statistically, you have like higher chances of being hit by a bus or than having a reaction to anesthesia or anything like that. But that being said, there is more risk from your surgeon and how good your surgeon is to what your outcome is going to be after the surgery as opposed to the anesthesia itself. So that I think that is like the biggest misconception that comes along with patients that I take care of and anybody really on my social media. Everybody's scared, and I understand it because being put to sleep, you basically lose all your bodily inhibitions. I mean, you can't breathe, you can't talk, and all those things. Everybody's seen the Hollywood movies where you wake up during anesthesia and that kind of stuff. So, and I would like to let all your listeners understand that technology has advanced significantly since those movies came out, and the type of anesthesia we use is much better at getting you off to sleep all the way. So it should not be a problem. But that being said, there are random cases as well. So I think that's the biggest misconception from patients is that the fear that they have of anesthesia. Now, with that being said, I would also just put the caveat in that, there are good anesthesiologists and CRNAs, and there's obviously people who aren't that good. So it is kind of user dependent a little bit as well. But in my opinion, the majority of your risk comes from your surgeon. If you have a great surgeon, you're gonna have a great outcome.
Thanks for putting that on us. But no, I think why a lot of the fear comes around from it because you have to go through like a surgical anesthesia clearance, right? Like obviously the physician will often determine whether you're healthy enough, you're fit for surgery. But I think that process of the, you know, pre-anesthesia screening and stuff like that, I think that can be daunting for a lot of people. But the reason why, and then the thing I think this is important for people to understand is that the reason why anesthesia has such a low risk is because they're doing these screenings. They're making sure that you're safe to undergo anesthesia. So, I mean, it can be a pain in the ass, but that it's just to ensure that there are no issues so that that risk is really, 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 really small. So you kind of alluded to it, this idea of undergoing anesthesia when you're under anesthesia. Are you actually like sleeping? I can't remember if I ever felt like rested. I've had surgeries before, ACL. I don't remember feeling rested because you're just so out of it. But like, are you legitimately sleeping? Is it like a coma state? What kind of state are you actually in? Because I don't actually even know.
Yeah, that's actually a great question. You're not actually, it's not the same as going to sleep. at the end of the day when you lie on your bed. You don't have that restorative feeling. A lot of people will say this is the best sleep I've ever had in my life, but all the research and data suggests that you're not actually, your brain is not processing the sleep the same way. To this day, we don't really know why we need to sleep, but the thought process is that it has to kind of, your brain has to kind of clear itself out or reset the memory or reboot or whatnot. And anesthesia does not provide the same level of sleep. Now, with that being said, we do have these mechanisms of detecting brainwave activity while you are asleep, and we can increase the depth of anesthesia to the point where you're in a comatose state, meaning there's no brain activity at all. So all the neurons in your brain are not firing because of the dose of anesthesia that we give. So we can increase the dose to the point where it's called isoelectric, meaning essentially there's no electricity occurring in your brain. Now, whether or not that is the same as being in a deep sleep, most data would suggest that it's not. But sometimes people come out of it, not sometimes, I would say more often than not, people come out and say, this was the best sleep I had in my life. And I think that has to do with the medications that we give. A lot of the times we give fluid as well. So when you wake up, you're like rehydrated. You usually get a little bit of steroids as well. And not the type of steroids that you guys prescribe, but the steroids that
Right.
just decrease all the inflammation in your body. So if you feel like tired or, achy and stuff, the steroids that we give, kind of just make you feel like a little like 5% better. So there is some truth to that you do feel better, but it's not necessarily from the sleep itself because as far as the data suggests, the sleep isn't the same.
So now, as part of the anesthesia kind of pre-screening, you guys kind of sit down with the patient and you ask them what kind of medications that they take, or maybe potentially any drugs. Now, we always tell patients, like, don't lie to your doctor. There's really no gain from it. There's one doctor you don't want to lie to, it's your anesthesiologist, because they got to know they about to put you, get you kind of get you down. Does marijuana use impact anesthesia?
Yeah, yeah. So it absolutely does. This is an interesting topic because it's really emerging, right? If you're keeping up with the news, I think Trump today or yesterday declared that he's going to make it a class 3 or schedule 3. And what that means is that, a lot more availability across state lines and it won't be regulated as strongly. So I would imagine the increase of marijuana use will increase significantly. Marijuana does impact your anesthesia in a couple different ways. The biggest of which being is that the marijuana vape pods are very inflammatory to your lungs and your throat. So it makes you cough a lot more. It does increase your risk for what they call a laryngospasm or a bronchospasm, meaning like your airways get all like twitchy and it could be, deadly in that sense. But more often than not, the real side effect of using marijuana a lot is your tolerance for anesthesia increases. So they kind of function on the same receptors, not necessarily all the same receptors. It's more akin to alcohol, but they do affect the same receptors in your brain and your body. So sometimes you end up needing more anesthesia to get somebody off to sleep who smokes regularly. Now, if you're an occasional user, I don't think it really impacts you that much, at least from what I've seen anecdotally. And I don't think there's a lot of research out there yet, but I imagine the research is going to ramp up in the next few years. But anecdotally speaking, if you're an occasional user, it's the same as someone who takes Xanax or whatever when they're anxious. But for heavy users, I tend to see that you need more anesthesia. What that means for your viewers and for patients is that if you need more anesthesia, anesthesia affects your entire body. It doesn't just affect your brain. So if we have to give more anesthesia, that's an increased chance of your blood pressure being lower, increased chance of impact to your heart, impact to your lungs, impact to your brain. And so the more that we have to give, the longer it takes for you to recover, and the more risk it is to your entire body, not necessarily just your brain, but your entire body. And I would postulate, maybe 5, 10, 15 years down the road, your risk of like dementia and that kind of stuff probably increases with heavy cannabis use. And interestingly enough, and you guys probably know this a little better than I do, but um, uh, a lot of research is coming out for heavy marijuana users, affecting like reproductive cycles,
Mhm.
affecting their ability to cancer, I
Conceive.
guess, their liver
Yeah,
and stomach and that kind of
conceive
stuff.
and stuff like that, yeah.
And so it's coming out like it's one thing to use it occasionally when you have a night out or whatever with the friends, but it's another thing to do it every single day. So I think there's like two distinct factors, and a lot of times patients get scared. They're like, oh, I smoked marijuana a couple weeks ago, and I'm like, it's not. It's probably out of your system. It's not going to affect anything. So
That's really helpful, and it is something that I think a lot of people don't realize because it is now used so regularly, and you're right, it might be used even more regularly with the new laws that potentially be coming down the pipeline. Now, we talked about marijuana though, but I live in Miami, And there's a lot more other party drugs that people like to use, right? And so when we're talking about party drugs, I know, and Kevin knows because we've both canceled patients. He's in LA. So obviously we've canceled patients for drug use prior because anesthesia actually had to cancel the surgery. So can you explain to us what party drugs are, can seriously put you at risk under anesthesia, and kind of like what those risks are?
Yeah, yeah, absolutely. So there's two that are that I talk about, and when I do my consent, I'm like, if you use these, there's a chance that you can die during anesthesia. So you have to be honest with me. Have you used them? And that's cocaine and methamphetamines. I mean, I guess crack can be in there too, but cocaine for the most part is a stimulant, same as methamphetamines, and they increase your blood pressure, increase your heart rate. But the most important thing that they do that impacts your risk during surgery is that it depletes your adrenaline. So I have seen it. When you induce anesthesia, your body needs to react. So anesthesia causes all your blood pressure to go down, everything to vasodilate, all those, because you're going into a relaxed state, right? Your body needs to recover. And in order for you to recover, it releases a little bit of adrenaline or a lot of adrenaline. And that increases your heart rate and constricts your blood vessels. So you don't have a blood pressure of like 40 over 20 after induction of anesthesia. Now, the problem with chronic use of cocaine and or use of cocaine within 12 or 24 hours before surgery is that use the night before depletes your adrenaline and it takes a certain amount of time. We recommend, a week most of the time, but that's, dependent on your institution. I've, done anesthesia for people as long as it's 24 hours, I think it tends to be safe. But a lot of institutions, err on the side of caution for 1 week. And that's because it takes some time for your body to regenerate the adrenaline and the adrenaline precursors, which is actually the more important thing is the adrenaline precursors. And so, because a lot of the medications we give as rescue medications use adrenaline to increase your blood pressure. And I have seen it where I've had to give epinephrine after induction because none of the other vasoconstrictors that we use were working, and the blood pressure was 60 and 50. And for those listening, normally it should be like 120. And when you use chronic cocaine or chronic methamphetamines, and I don't know what the kids are calling methamphetamines these days, but um,
Molly, MDMA.
same. I guess it's the same since I was a kid. But
Yeah.
they
Ecstasy.
ecstasy, and I didn't even recognize ecstasy was a methamphetamine. But I guess the problem is that the blood pressure. Now I forget my train of thought. But
Sorry.
essentially, is the blood pressure effect. It decreases your blood pressure and doesn't necessarily allow it to rebound.
That doesn't
Yeah.
impact by Adderall and everything, right? Adderall is okay.
Yeah, so Adderall typically doesn't give you enough to stimulate a high. So it's I mean Adderall is essentially the same thing, but Adderall is a little bit lower concentrations. And the other thing I was going to say is methamphetamines chronic use cause your blood pressure to typically be lower at baseline too. So, if you chronically use it like every Thursday, Friday, Saturday night in Miami, your blood pressure on Monday, Tuesday, Wednesday is probably like 90 over 60, and your body's probably used to that, but it's not used to getting a big dose of propofol to go to sleep. And so that's where the risk comes.
So we were going to talk about this later, but I think maybe we can kind of bring it up now. What about like you see a lot of ketamine clinics, but also people use ketamine recreationally as well too. So I mean, I'm assuming that's got to be also one that probably got to be a little bit careful about, like using around the time of surgery.
Yeah, no, that's interesting. I don't have a strong opinion. I mean, on ketamine there's a couple of risks they teach you about in anesthesia. It's like you can cause sympathetic drive of your heart to go devastatingly low, essentially max out your heart when you give ketamine on somebody who's in like extreme heart failure. But aside from that, ketamine of all the like I guess street legal drugs or not street legal, street illegal drugs that are out there, it's probably the one that has the least risk to you, both
Yeah.
systemically and life-wise. It is like an NDMA receptor antagonist, so it does help with like depression, anxiety, outer body experiences, all those kind of things. But as far as like respiratory depressants, it's not really a respiratory depressant. It's not really something that like opiates or that kind of thing, like the fentanyls and all that. And it's not necessarily something that like maxes out your adrenaline in your body. But that being said, I would not recommend you do it. But like of all the ones that are, of all the ones that are, yeah, of, of all the ones that are bad for you, that is probably the lowest on the
The lowest one.
bad. I mean, I guess marijuana is below that, but like the ones in Miami, so
Yeah,
can't live.
it's a good point.
And
So, I mean, there is another rumor, like when we're talking about difficult anesthesia. is redheads. I've been in the OR where, I'm like, what's going on? It's taking a little bit longer. And they're like, redheads, man, redheads. And is it true then that redheads, natural redheads, of course, not dyeing your hair, um, are these patients are more difficult to put under anesthesia?
Yeah, it's interesting. There's actually a lot of literature on it. There's a gene mutation in redheads. It's called like MCR or something like that, or MCR1 or it's something along that. But essentially, it means that redheads require about 20% more anesthesia. It's not
Wow.
whoever was saying that to you was probably bullshitting, to be honest, because it's not like they need to. It's not like it takes them like 20 minutes longer to fall asleep or something. It just means that you have to give a little bit of more, like 20% more of a dose. So a typical dose is about 200 milligrams of propofol for induction for a healthy, for like a healthy, I don't know, healthy 21-year-old, it's probably 300 milligrams of propofol to go to sleep. So for like a healthy redhead 21-year-old, it'll be like 360. So it's not like, they need an extra 15 minutes to go to sleep. It's just that they need to dose up the propofol. So yes, it is true redheads do require about 20%, 21% more anesthesia by the literature, but it's not always the case. There's plenty of times that redheads just go to sleep with the regular dose as well. And I typically don't overdose redheads when I induce. I just give extra if needed. I don't just start off the bat with a 20% more dose.
There's not like a red hair like that's on the like on your form. You're not like, oh, patient's got red hair. Gotta.
No, none of that. You see that it's a question I ask a lot of the time. Like, are you a natural redhead? Most of the time they say they're dirty blonde or something. So I do ask it. So
Now, Justin and I, we do a ton of surgeries for like patients who are undergoing like male infertility issues. I've actually had a question where a guy came up to me during one of these pre-op visits and he asked me, he's like, can anesthesia impact testosterone levels or even my fertility?
yeah, that's interesting. I've never heard, and I don't think the literature says that it actually impacts directly your testosterone levels or your sperm fertility levels. There's no real research or breaking news on that. But I did in preparation of this podcast, I did look it up a little bit, and I saw that there was some articles on the stress of surgery itself impacting testosterone levels, but not necessarily the anesthesia. And I guess people do think that I guess if you give Decadron or any sort of steroid, that can impact a little bit of the testosterone levels. But that's all transient, from my understanding. There's no permanent issues there. The only other thing I could really think about or think of is that the operating rooms are very cold. So if you are under anesthesia for a long period of time, maybe that cold, extreme cold, and I'm talking like 70 degrees, 65 degrees, not like 20 degrees, but that level of cold and exposure of your genitals could potentially impact your testosterone or your sperm. But that's kind of as far as I got. I didn't really find any hard evidence that says anesthesia impacts hormones or testosterone.
I'm not convinced it does. Kevin, do you?
No, no. I mean, look, you could have maybe some very mild transient, but none of it permanent, right? But your body's transiently undergoing changes all the time.
Yeah, and I also think there's actually really good literature now that, optimizing your testosterone levels prior to surgery in many surgical outcomes, and this is not really regarding anesthesia, this is just in surgery in general, your outcomes are better in terms of reduced risk of infection, recovery, especially in the orthopedic space, that there's really good data showing that having good testosterone, taking care of yourself prior to surgery, you're really preparing yourself and setting yourself up for post-operative success. So, I think that it goes to a bigger picture of how you treat your body prior to surgery, which is kind of the theme for all of the risks that anesthesia has come with, which is what you've been alluding to here.
Yeah, I agree.
Now, what are the real common side effects of general anesthesia though? Because if I'm going, should I expect to have nausea afterwards? Should I expect to be forgetful for the next 12 hours? Like, do I really not want to eat a big meal when I'm
Yeah, yeah, that's a great question. I mean, that's probably the biggest question that I get, or the most frequent question that I get is the risks associated with it. Number one, like you said, is postoperative nausea, vomiting, and that's very common. I would say it's probably like 25% of patients have postoperative nausea. To some degree, some people have it way worse, some people have it way less, but it also depends on your history. So if you've had surgery before and you had PONV, there is a high likelihood, even if we give all the medications, that you will probably feel nauseous afterwards. there are certain anesthetics that we can do that decrease excuse me, decrease the risk of nausea afterwards, but there's no like 100% silver bullet. And most of the time, the postoperative nausea is transient, so it lasts for a couple hours, and then it goes away as your body kind of flushes out the narcotics and the anesthesia meds out of your body. But sometimes it can last like up to 72 hours, which is horrible and requires admission and your IV fluids and all that kind of stuff. And I've only seen that a couple times in 10 years of practicing. It's not very common. Other, kind of side effects that you hear about from patients is shivering. That's usually related to like your stress, your adrenaline and that kind of stuff. Post-operatively, the anesthesia decreases a little bit of your body's response to, or your body overcompensates with adrenaline after the anesthesia is gone out of your body and stays for a little bit. And you guys probably know it better than I do, but it's usually like 30 minutes to 45 minutes it takes for the adrenaline levels to come back down to normal. And so you shiver in the recovery room. And it's not necessarily because you're cold, it's because your body is just overstimulated. You also see that a lot in C-sections. After you get a spinal done, patients tend to shiver, and it's because half your body is not feeling anything, and half your body is about to have a baby. So you tend to shiver, and so that's one of the common side effects, and also sore throat. Usually from the ET tube that we place, which is an endotracheal tube that helps you breathe during the surgery, and that is something that sucks. And there's no real way to prevent that unless they come out with like I guess cushiony ET tubes, which would be a great idea that is thought of. But aside from
Yeah.
that, there's
Oh,
There you
we
probably
go.
got like a
that's
10% bonus
$1 million.
on that.
There's some damn memory foam on it or something. I don't know. But aside from that, that one kind of sucks, and that usually stays for like 6 to 8 hours after surgery.
Actually, that brings up a good topic I think our listeners would be interested in. Just kind of going over the different types of anesthesia. I mean, we throw around these acronyms like under MAC, LMA, general anesthesia. So maybe could you go
Yeah.
over with the listeners just kind of like quickly or topically like what those differences are?
Yeah, yeah, absolutely. So, if a lot of your listeners are urology or in urological procedures, there's a couple options that we can do that don't even require you to go to sleep all the way, and that's what we call as regional anesthesia or spinal anesthesia. That's like an injection in your back that numbs up your body from like your belly to your toes, or it's an injection somewhere in your limbs. I guess you guys don't really do that as much, but we can numb up a certain limb, and you can perform surgery on it and be awake all the way. Like if you wanted like a arthroscopy of your knee or something like that, you could theoretically do it awake completely. Most people don't want that because they don't want to hear the orthopedic surgeon kind of banging on their knee and stuff. But you could do it under that. There's also an option called MAC, which is essentially anesthesia sedation, IV anesthesia sedation, very commonly used for like scopes for you guys, scopes for GI doctors, when you don't necessarily need the patient to be completely still. So, typical example for your listeners, like if you're doing a cysto and you're not doing a laser, a lot of the times the urologist will say, I'm fine with the MAC. And then sometimes when they do lasers, they want the patient to be like completely still. So we give a paralytic. And in that instance, we have to place a breathing tube because if we give a paralytic that affects your entire body, it also affects your diaphragm. And when it affects your diaphragm, you don't breathe. So we have to place a breathing tube to breathe for you in order to keep your entire body completely still during the surgery. And so those are the kind of different levels. And there's also, like Kevin had mentioned, a LMA, which is a laryngeal mask airway. Essentially, it's a airway device that doesn't go into your trachea, it just sits on the outside. It can breathe for you, but it's usually there to help you breathe essentially under a deeper version of general anesthesia, but not necessarily requiring paralysis or paralytic. So you could think about like a knee surgery, even a scope for you guys, or even something that doesn't require the patient to be completely still, but you also need the depth of a general anesthetic because it is potentially painful to the patient. So we can't numb it up or stop the pain. So those are the kind of different options that you can have during surgery. Most commonly, you can just ask your provider or your surgeon, or even I guess ChatGPT, what surgery you're going in for, and then just ask them, what's the most common type of anesthesia, and it'll probably spit out a nice little explanatory thing for you.
No, I think that's a really, really good breakdown. And sometimes you do have a choice, sometimes you don't. And that's really dependent on the surgery, dependent on the surgeon, and sometimes dependent on your health, right? Like I think
Yeah.
sometimes, your body habitus and all these other things can really make an impact on what kind of anesthesia you're going to be getting.
Yeah.
And talking about body habitus, I think obviously we are now in a new world of GLP-1s, which it seems like a large majority of people are starting to consider who are obese, and sounds like they should. The data has been really promising, and more than just obesity, cardiovascular renal protective, and potentially testosterone. There's some data, fertility now. So we have a lot of people on GLP-1s now, and that has, and the way that GLP-1s with the delayed gastric emptying has impacted anesthesia, or can potentially impact anesthesia. So can you explain how GLP-1s impact anesthesia and what people who are on GLP-1s need to know prior to undergoing anesthesia?
Yeah, it's a great hot topic. That's if you listen to the GLP-1 ads like Manjaro or Ozempic, you'll hear at the end they say if you're going for an anesthesia, if you're going
Yeah.
for a surgical procedure, make sure you let your anesthesiologist know. Now it's a little bit controversial. Initially, when they came out, there was a 2-week recommendation on stopping the GLPs. Now they've kind of shrunk it to 1 week, and then now there's more literature coming out that if you're not in the ramp up phase for on a GLP-1, you don't potentially need to be off of it. Now, why? What's the reason? Why are they talking about it? It's because there's delayed gastric emptying, like you have mentioned. So when there's delayed gastric emptying, it just means that the belly or your stomach doesn't, the food, excuse me, the food doesn't sit, or the food sits in your stomach longer than it's supposed to. So you could potentially be NPO, meaning nothing after midnight. But if you had a meal at 8 p.m., it could potentially still be in your stomach at 6 a.m., 7 a.m. when you get induced for anesthesia. Now, the risk is, like we talked about earlier, when I give you the medications that relax your entire body and every single muscle in your body, there's certain sphincters that are on the outside of your belly or your stomach. Sorry, not belly, but outside your stomach that prevent the food from coming up. When we give the medications, sometimes that stuff can come back up. And when it comes up in the form of food and acid, if it gets into your lungs, it can cause a pneumonia, pneumonitis, and potentially even death from asphyxiation. Essentially, you drown in your own stomach food. Like imagine a piece of steak comes up and goes into your trachea and it just blocks your trachea. So that has happened, and there were some horrible outcomes that they reported when the GLPs first blew up a couple of years ago, and so everybody got real cautious. Now there's like this whole push to do like an ultrasound before if you're on GLP-1, which a lot of people, it's very hard to see the stomach and see food inside your stomach with an ultrasound, especially if you're morbidly obese on these medications for
Yeah.
that. So the safest thing from what I've seen most institutions do is they implement like a 1 week, be off of it for 1 week. Most people have their injections on a Saturday or Sunday from their clinic or at home or whatever, wherever they get it. So they tell you to stop it, not the Sunday before, but the Sunday before that. And that kind of bleeds into like a 10-day period. And so far, fingers crossed, I haven't had any issues with it. But I also, when I put someone to sleep who is on a GLP-1, you like we talked about for a MAC anesthesia, you're more likely to do a general anesthetic because you don't want to risk, just the off chance that there's more acid in your belly or whatever, or someone pushes on it slightly harder. You don't want to risk an aspiration event because aspiration can be deadly. We tend to take more precautions if you're on the GLP-1s. But that being said, I've talked about it at length on my social media. The GLP-1s seem like they treat everything from depression, anxiety to cancer to obesity to heart disease.
Yeah.
So there are way more positives for it. So anesthesia risk should be pretty low. But if you are on them, it's very important you tell your anesthesiologist the day of because it could be a risk to your life. In that small instance.
All right. Now, supplements is the next question that I want to get to. Supplements, Dave, they've always been popular, but now I feel like they're even more popular than ever, and people are taking supplements for everything. So are there any supplements, and we'll kind of focus on men, that they should be avoiding prior to undergoing anesthesia?
Yeah, it's an interesting topic. I'm a little bit more liberal on the supplement side of it. Now, people will tell you about like St. John's wort, berberine. Berberine is like a GLP-1 analog, and they'll tell you not to take those. And I tend to agree with them. But that being said, I would never cancel a surgery for it. The bigger ones that I think are a little bit more riskier for anybody going under surgery, someone who's on high dose like fish oil, those can be blood thinners in a sense, and they can cause excessive bleeding during surgery. So anybody that's kind of on fish oil, garlic, ginseng, I think, as well as it's ginkgo biloba, those are all supplements that can potentially increase your chance for bleeding during the surgery. Now, it's not something that I would say you can't have a surgery for, but if you think about it ahead of time, it would probably be smarter, beneficial to stop those supplements. If not, you could potentially stop all your supplements before, even your multivitamin, like a week before. And it should not impact your health because hopefully you're not relying on whatever supplement you're on to treat major problems in your life. But that being said, ask your anesthesiologist or your clinic beforehand. I've never personally canceled a surgery for somebody being on a supplement. That's not something in my book that seems like it's risky. The benefit risk ratio doesn't really add up in my book, but I know some people who will. If you're taking fish oil and like vitamin E, they'll say, no, I can't do this. I don't want to risk a bleed or whatnot. So it really just depends. It's kind of gray area just with all supplements in general.
Kevin, do you tell your patients not to take any specific supplements prior to surgery?
Me, no, not anymore. So part of the practice I was with before, one day, they go in, you kind of always kind of just assume whatever kind of workflows are going on. And one day I saw like the actual, the whole list of medications, even just for like a vasectomy, like all the different like herbals, just like you said, like some of these can cause increased bleeding potentials. And the way I tell my patients is like, look, you can refer to the list, but most likely I'm not going to cancel a patient depending on the procedure. Most likely not going to. I don't know, Justin, if you.
No, I mean, other than if you're like taking aspirin every day and it's an elective case, I'm gonna stop you there. Like, but if you took ibuprofen, I don't really care, for the most part, but supplements, I mean, unless I try if they're on like blends, I really don't like blends in general. And I think we've all talked about I don't think any of us are really on fans of blended stuff because if you're at least saying you're taking magnesium, I'm hoping you're only taking magnesium, at least in that not FDA regulated supplement. But, with these blends, there's a higher risk of contamination, other random shit. So I have thought about in the past being like, hey, if you're on a blended supplement, which I've already told you I really don't like, maybe hold off for a week just because I don't know what's in those products. But for the most part, no, I have not canceled a surgery at all.
Yeah, I will add on there. I think there, even if you're on, I tend to not cancel surgeries unless that there's some protocol that the hospital has put out and they're not following the protocol in the hospital. A lot of the times in anesthesia, we can counteract majority of the things. Even if if you're on like a Manjaro or an Ozempic and you have to go in for an emergency surgery, we have ways of mitigating it, and that's the reason we get paid what we get paid. But in order to kind of optimize your chances for not having something go bad, you should follow the rules, But most of the time, like for me, I rarely cancel surgeries for anybody on medications or anything like that. The GLP stuff is really hospital specific or institution specific, and because I personally don't take the risk upon myself. So if somebody's like, if a surgeon's like, hey, you took it like 6 days ago, I'm like, man, this is the policy. This is just it is what it is. I'm not gonna, go against the policy and something bad happens. But that being said, if it's like a fish oil or if somebody's on like whatever, I'm like, here's the risk. But as long as you understand that, let's go ahead and you've already not eaten or you've already, done your colon cleanse or whatever it is. So let's go ahead unless you feel strongly about your risk on your side.
Yeah, I mean, the bottom line is we understand people have taken off of work. They've taken off like a week of work if they need to recover afterwards, and we don't want to just cancel to cancel, right? Like if we understand that there's your health's here and we're prioritizing your health, we also understand that, you're spending a lot of sweat equity, maybe financial loss to actually even just get to the office and get to the surgery spot. So, we try to accommodate as best as possible. And I think that's another separate layer, but I've canceled surgeries and I will continue to cancel surgeries if I think that your health is at risk too high. And I know Kevin agrees. And I know Zane agrees for that aspect as well.
Yeah. I will say people lie all the time too. So I see it all the time, man. I'm like, did you do this? And he's like, no. And then under anesthesia, I'm like, this guy needs like 3x the amount of normal anesthesia. It doesn't make any sense. People do lie all the time, and
Yeah.
and it's not outside the realm of normal for coming into surgery. I mean, people say they don't eat, and then you suck in their stomach, and you see there's like a cheeseburger in there, and they had food in the morning. So people take the risk upon themselves a lot of times too. And so I try to just weigh. You're coming in for cancer surgery. It doesn't really matter if you took in, I don't know, took whatever fish oil this morning. Your cancer is more important to me getting that out than the risk of chance of bleeding. So it's just an individual decision for anesthesiologists.
Now, Kevin brought it up before, ketamine. It is a very, very hot topic now, especially as an outpatient treatment. I would like to know more about it. Can you give us a little understanding of what ketamine, how it works, and why it's becoming so popular as a treatment therapy, as an outpatient, as an out?
Yeah, I'll give you the unabridged, unhinged version of it. It's because It's because it's easy. So it's a cash cow, it's cash paying. There's not a lot of risk to providers when you do it. Like I said earlier, like ketamine doesn't cause so what it's used for? It's used for depression, for anxiety depression, for bipolar depression, for anything that's refractory depression, like you've tried all the depression meds and they don't work. You can go to a ketamine infusion clinic, which is essentially like this gray area thing, but ketamine does help with depression based on literature. So you can go to a clinic, they put in an IV, they infuse like a baby dose of ketamine for an hour. You kind of trip for an hour, sit in a chair, watch, whatever. And then there's like a nurse or somebody who can manage an airway, like a CRNA or an ER doctor or something, or nurse practitioner walking around to make sure you're not, throwing up and whatnot. And usually they sit you up. So there's very little risk of that happening. And then you pay cash, right? So you come in the first time and for the most part, you pay your initiation fee, which can be like $500, and then every subsequent treatment is like $250 or whatever your pricing is in your city. It's not hard to set up, and it's also not hard to see why there's a huge incentive to do it because let's say you have a clinic with 10 chairs, right? You have 10 chairs set up, two providers just walking back and forth to make sure nothing happens, and then you have 10 people who come in 2-hour slots in an afternoon. You could have like three of them, right? Like at 4, 6, and 8 or whatever. You're looking at like 20, 30 grand a day, maybe 40 grand a day just from doing these clinics if you can get enough people there, right? And then your overhead costs and paying your provider and then getting the medication is probably minimal, and the rent, for the most part is whatever. And so it's a cash cow. And in the beginning when it first came out, it was a little bit of taboo and not a lot of people want to be associated with it. There was a chance of abuse. Nobody really knew. But since then, psychiatrists do it, anesthesiologists do it, our doctors do it, and now it's kind of branched out into nurse practitioners and all that kind of stuff. So they're kind of everywhere. They used to be just like one in a city. Now there's like multiple clinics, and the efficacy of it is a little bit controversial too. If you go to a clinic and they infuse ketamine in for an hour, you're gonna feel better afterwards. For the most part, right? There are some people that feel worse, but if you get any sort of like medication, and the trick with ketamine is that since it acts on the NMDA receptor, it does cause like you have an outer body experience. So it's very similar to those kind of like retreats that Aaron Rodgers goes on and that kind of thing, but a lot dialed
Ayahuasca.
down. Yeah, Wasco, whatever. It's like
Yeah.
dialed down, right? So you
Yeah.
can kind of go there. You're in a safe environment. Like nothing bad's gonna happen. You're sitting up and you're going to feel better afterwards and objectively or like subjectively speaking when you take the quiz at the end or whatever you're going to say you feel better and so maybe it does work. I'm not saying it doesn't work. I just know that the incentives are kind of messed up for it now because it's cash paying for the most part. I don't think a lot of insurances really cover it. I think insurances tend to push you toward like the ECT for refractory depression, which is like they shock your head and put you in a seizure for 30 seconds. And so that's what they push for. But the ketamine clinics are kind of akin to like IV clinics, in my opinion. And so they've kind of popped up everywhere. I imagine there's probably mobile ketamine clinics now too, where you could kind of go to people's houses and charge them, a lot of money. But it's a slippery slope, right? You end up with like Matthew Perry type of issues and those kind
Mhm.
of things that happen.
Mhm.
And it's a drug. It's not necessarily like something that's benign. You can have a bad outcome. Somebody could throw up and aspirate, and if you don't have the equipment there to save, if there's just one person there who's trying to manage 10 people that are getting, if you there could be hairy situations, right? So it's not something I'm a fan of, but I can see why people do it. I can see why it's so popular because you could make a lot of money doing it like 3 or 4 nights a week and not ever have to work at a hospital again. And so, to each his own, I believe.
It is. I mean, it's crazy, and you bring up so many good points there. And when the incentives may not necessarily, if there's like a cash incentive for whoever's running the business, you starts kind of getting, we see this a lot in mental health, Justin and I, when it comes to look, medicine is this weird area where like we want to help people, right? We want to help people, but at the same time business, no matter how far away you want to get from it, is very still integrated into the whole idea of practicing medicine, whether it's through insurance or without insurance or whatever. Some of these treatments that we see in mental health that Justin and I've talked about, even like just talking about ED meds, like to keep that business afloat, you got to keep giving more ED meds. And so yeah, it can become a slippery slope. And ketamine's just become, I feel like, so ubiquitous. I feel like in LA, you like walk around, start seeing like these signs for like ketamine clinics. It's crazy. It's just, I felt like it
Yeah.
just came out of nowhere.
I don't know. I kind of see it. So I think to your point, Kevin, too, just because it's cash doesn't necessarily mean it doesn't work, right? Like, we have direct to consumer TRT clinics. Obviously, I think they're almost analogous in many ways, where I think that there are really good ones that do it really well. And there's ones that just you walk in and you can do it. But also at the same time, what you just described to me, sometimes these things are a little ahead of its time. We need people to do this stuff to get the data. So I do appreciate some of that. Also, I'd probably rather try ketamine than getting shocked. I don't know. So like, if you told me that like I had to pay a little extra to not get shocked and maybe trip out and feel a little bit better, I kind of get it.
Yeah. Yeah.
So
Yeah.
I
Yeah.
think that, I think it's important, like anything, to acknowledge that, yeah, there's potentially bad players, there's potentially good players. It's probably not going to work for everyone. And we're probably, doing a bad job of screening who is the right candidate for these things, just like we do for testosterone. So I think it's always going to be, from my perspective, and obviously I don't know as much about ketamine in general as you, is always user beware, patient beware, do your research, make sure the person that you're going to understands this. They have the proper setup, like you're talking about. You have to understand the risks and, understand the course and understand what you're getting into before you're buying into it. Another long-term risk of ketamine that people don't talk about, that Kevin and I do know about because it's on our boards, I've never seen it, is ketamine bladder. So ketamine actually has a secondary effect where it can cause fibrosis of your bladder in chronic usage. So your bladder shrinks. There's unfortunately no treatment. You just pee a lot. You have to pee a lot more because your bladder shrinks, and it's just not as stretchy. So you can't hold as much urine. You get urgency more frequently. I've never seen it. Someone once told me they went to a urologist because they thought they had ketamine bladder in Miami, one of my patients, but they didn't. But yeah, so that is one thing that I think you have to do a whole bunch of ketamine to really be at risk for that. But it is another side effect potential of ketamine.
Yeah, that's interesting. I hadn't even heard of that.
Hopefully you never see it, and we never see it.
I don't give that much, I guess.
Yeah. I think for our part, just one final question for us is, what is one message, I think, from all these conversations we had today, it's been a wonderful conversation, that you think guys should walk away with about anesthesia from this episode?
Yeah, I think the biggest take home message for me is that as an anesthesiologist and been practicing for 10 years, I've probably seen it all as far as things that could be really weird, syndromes that you have, medications that you take, recreational stuff that you do. If you have any issues with your heart, lungs, kidneys, and if you recently had any changes, I think the biggest thing for anybody going into surgery is to be honest with your anesthesiologist, because all the doctors you really see, you can kind of fudge things here and there and still get to the same endpoint, but for surgery, and especially when you go under anesthesia, it's like a hard stop. And so there's a giant risk to your life if you don't completely divulge all the information that your anesthesiologist asked for. And I've been stuck in situations where I couldn't figure out why something bad is happening until afterwards, and you find out on a urine tox screen or whatever it is. And so being honest and upfront could potentially be the difference between life and death for you when you go under surgery. So I think that would be the take home message for me, is that, hey, just be honest. It's not going to really, the anesthesiologist is really there to kind of make sure that you make it through whatever surgery you're having.
Well said. Well said. All right. So tell our listeners, Zane, where they can find you online if they haven't already, because you've got a great follower set a group here. But tell our listeners where they can find you.
Yeah, guys, you can just look me up on Instagram. It's Dr. Zain Hasan. Same on YouTube, which would be great if you could follow me there, because I'm trying to get one of those plaques to stick up on the wall behind
Hell
me.
yeah.
So Dr. Zain Hasan on both of those. And I think on TikTok, it's Dr. Zain Hasan 1, because somebody stole my name. Or I changed it. I tried to change it. So because I think it's Dr.
You
Zain
gotta
Hasan.
find that guy.
Yeah, if you're
dude.
listening
Yeah.
out there,
Screw that
this is
guy.
arraigned
Now
Dr.
there's
Zain
like 8, 9,
Hasan.
10, like a million people after it now. Yeah, you can, or just Google, Dr. Zain Hasan. I'll pop.
All right. Awesome, man. Thanks for coming on. As always, thanks to our listeners. Download, subscribe, give us a review, 5 stars. You can find us on all podcasting platforms. YouTube, we really want to push our YouTube. We all look great. Zane looks great here, so you should be watching us on YouTube for sure. But until next time, thanks for listening and have a good one.